We are live. It's Dr. Centeno here with Dr. Linda Bluestein. So we have an interesting one today. Dr. Bluestein, I met through seeing CCI patients, and ultimately, there aren't that many experts out there in EDS and hypermobility. There's a few physicians that have taken it on. But Dr. Bluestein developed a Bendy Bodies podcast, which is quite popular. And so I thought I'd have her on just to see if we can get a conversation going about EDS, about CCI, and all of that good stuff. Welcome in, Linda.
Thanks so much for having me.
Yeah, so how did you get started in this whole hypermobility thing, right? It was my understanding that you were a practicing anesthesiologist for a long time, and then your career kind of took a different direction. So tell us all about that.
Yeah. So I worked as an anesthesiologist in the traditional operating room setting for over 2 decades. And I had various different health problems throughout my entire life, but they started kind of accumulating. And then I developed a Tarlov cyst. And as I was reading about Tarlov cysts, I came across a sentence that said, Tarlov cysts are more common in people with connective tissue disorders. And at that time, I was still working as an anesthesiologist, but I ended up ultimately having Tarlov cyst surgery. And in the process of all of that, was like, oh, I wonder if I have a connective tissue disorder. So I started reading about hypermobile EDS, and I was like, this could explain my entire life. So I saw a rheumatologist who, the first one gaslit me, but the second one was wonderful and did a very, very detailed physical exam, not just the Beighton score, but, very detailed, and said, yes, you definitely fit this criteria for EDS. And that was pre-2017, the new diagnostic criteria for hypermobile EDS. But so I had that evaluation, and I had the Tarlov, and then I ended up having the Tarlov cyst surgery, actually reverse order. And then I was able to get back to work in the operating room for a few years, but then I developed a huge cyst inside my lunate, inside a bone in my wrist. And I had bone grafting surgery for that, and I got CRPS. So instead of being able to go back to work in just a few weeks, like I thought I would after the surgery, that turned into a much more prolonged being away from the operating room. And I already had an unstable shoulder. I already had a submuscular transposition of my ulnar nerve. And this is my airway arm. So that was kind of the sign of, okay, maybe this is not a viable path any longer to work in the operating room. So I was trying to figure out, well, what am I going to do when I grow up? And I was still going to anesthesia conferences, and I met somebody who was the editor for a pain management journal. And she asked me if I would write an article. So I wrote an article about pain management and EDS. And I had people, of course, emailing me and saying, where can I come see you? And I had to say nowhere. But then later on, obviously, I decided to open a clinic focusing on pain management and EDS. And of course, pain management is something that you learn as an anesthesiologist. I learned how to do a lot of the procedures and things that I know you all do in your clinic. I don't do those procedures now for a couple of reasons. One, wearing lead is very painful for me. I can do it for a day here or there. I came to your clinic a couple of times and observed some procedures. So I wore lead then, of course, but wearing lead day in and day out would be very challenging. So I take a medical approach to treating people who have symptomatic joint hypermobility and connective tissue disorders.
And so it sounds like, obviously that was a huge career change there, but it sounds like it's gone well, right? I see the Bendy Bodies podcast all over the place. Tell us how it's going. How did you? That's a great name, Bendy Bodies podcast. So, how'd you come up with that? What's going on with all that?
So my son, Zach, came up with the name. I have to give him credit. I was, throwing around all different names for the podcast, and I had launched a podcast previously with Carrie Gabrielson. That was in 2018 or so, called Hypermobility Happy Hour. But I wanted to do my own thing. I had kind of a very specific vision of how I wanted to do it. So in February of 2020, I believe is when we published the first episode of the Bendy Bodies podcast. And I started out making it very dance focused, because I knew that there's a ton of dancers that have joint hypermobility that may become symptomatic in the future. And so I really wanted them to have the information in order to know how to take care of their bodies. And, oftentimes you get advice like I did as a dancer, oh, just stop dancing. Well, if you love to dance, oftentimes what you're going to do is you're just not going to listen to that doctor. You're never going to go back to them. So I wanted to give them other tools besides just stop dancing. So when I first started the podcast, the first few years, I had a wonderful co-host, Jennifer Milner, who's a former professional dancer and Pilates instructor. And then I started getting deep dives into, some very significant medical topics. And, for scheduling reasons and things like that, it was easier to, start hosting on my own. And then this past year, I actually had a professional company that's publishing the podcast for me. So they're doing a tremendous job with editing and things like that. Of course, that always makes it trickier from a cost standpoint, but it's wonderful that, this past year I was able to publish an episode every single week. So this past year, 52 episodes. So that's a lot.
That is a lot, for sure. I know that one well.
Yeah.
So give us a sense of your philosophy on managing patients. I mean, there's probably nothing better than a doctor who has EDS treating EDS. So I'm sure that gives you lots of insights that other people just don't have.
Mm-hmm. Yeah, definitely. And, what I've really learned is every person is so incredibly different and so incredibly unique, but I feel like I've gained so much from my patients. And I also have clients, which we can talk about in a little bit what that means. But by talking to, thousands of people now, I've just gained so much more knowledge. Of course, I know what my body feels like, but in talking to so many other people and working with people and now having, I guess I opened my clinic in 2017. So now having, 8 years of experience with that has really been very helpful for me to learn so much more, because of course you learn through going to conferences and reading and, publishing and doing your own research and things like that. But you really learn from talking to the patients. And so I already had this, protocols that I was using on myself and various different things that I was doing for myself. And I was talking to my husband one day, who's also a physician. And I said, I think I need some way of describing this better. And he said, well, let's see if we can come up with an acronym. So we came up with the acronym. Actually, I guess I should credit him. I think he came up with the acronym MENSPMS. And that stands for movement, education, nutrition, sleep, psychosocial, modalities, medications, and supplements. So those are the 8 things that I really try to focus on when I'm working with somebody. And when I'm seeing them back in follow up, oftentimes I've learned about some new supplement or some new procedure or have more data about a procedure. So we'll talk about, okay, well, is this something that you should consider at this point in time? Is your CCI getting to the point where, you need to start thinking of doing something more than, physical therapy and working on your nutrition and working on, restoring the curve in your neck and things like that. So I really appreciate the incredible patients that I have. They teach me things every single day, and they are dealing with so many of them. So it's been a very interesting journey for sure.
And so when it comes to CCI, I mean, what would you say? You've got obviously, unlike our clinic, where a certain subset of our patients have EDS that also have CCI, what's your sense of the percentage of hypermobile EDS patients walking around out there that have some sort of, I guess we'll limit it to symptomatic CCI, because many of them probably have excessive motion lots of places, including their upper neck, but symptomatic CCI.
Yeah, that's the tough one, right? Where you draw that line of like symptomatic, because, I think, symptomatic can be related to so many things. It can be that it's presenting as, a lot of pain and tightness in your neck and your upper back and your traps and your shoulders and things like that. So, I definitely have had mild CCI for sure. I've been in and out of physical therapy for my neck. And when it comes to, more serious, more, symptomatic, and you need to be doing something more than physical therapy, working on pain management. I mean, one of the things that I talk to people about is like, if you have pain in, almost every joint in your body, that's obviously very different than if it's, if your neck is like this huge problem. And especially, of course, if you have neurologic signs and symptoms, if you have swallowing difficulty, visual problems, tinnitus, things like that, then we have to, of course, be taking that more seriously. So people who have more symptomatic CCI that's like, beyond kind of the rest of their joints, that's kind of hard to quantify, but I would say maybe 25%. I'd say on the scope of some kind of CCI, probably 90%.
Yeah, it's interesting because I would say that that's about what we see. About 1 in 4 of our patients is hypermobile. So that's interesting to.
That is interesting, yeah.
To hear that. Okay, well, let's get to some questions because we got lots of them coming in here. So the first one, can you see that on the screen there?
If I put my glasses on.
I'll read it for you as well. So I never knew I had EDS until a doc told me because I bend my thumbs to my forearm. That means I'm hypermobile. I'm 3 weeks out from PICLs and normal for symptoms to get worse before they get better. After PT, I'm going to schedule my second PICL 4 to 5 months out. To patients with EDS typically see the same outcome from PICL compared to someone without it. Well, maybe that's more one for me. Yeah. So Caleb, on PICL for hypermobile patients, we'll work backwards. The good news is that we just are looking at the most recent case series of 242 patients. And in that case series, the hypermobile patients are performing quite well. Actually, they have better headache improvement scores than normal ligament people. So that's good news. And it sounds like you could be in the donut hole. You get initial inflammatory response for 1 or 2 weeks. Things feel maybe sore, but they're tighter. And then that initial inflammatory response goes away. And then it takes a good 3 months or so to get to the other side. Linda, this is a good one for you here for Snowmass.
And I see like a recording error message. So I just wanted to like quickly close a couple of things. Are you getting that on your end or no?
No.
Okay. I always get nervous about that if we're recording a podcast or something, so we don't want to, I don't want to goof up your recording. So I'm closing a couple of things. Hopefully that'll fix it. And I did want to, can I quickly address the comment that they made about touching their thumbs to their forearms? It's important to remember that there's multiple different kinds of joint hypermobility. So a person can be able to do that, touch their thumbs to their forearms, and not have a connective tissue disorder and not have generalized joint hypermobility. So oftentimes I think people think, oh, I'm hypermobile, or maybe a clinician thinks, oh, I did the Beighton score and they had a high Beighton score, therefore they have EDS. And we need to remember that EDS is a group of connective tissue disorders, and it includes joint hypermobility, or I think probably even more important, joint instability, as we're talking about with CCI, right? Tissue laxity, so that could present as pelvic organ prolapse, hernias, various different things, and then also changes in the skin. So it could be skin hyperextensibility, abnormal scarring, unusually soft and velvety skin, things like that. So I just wanted to point that out because I saw that person made that comment, and they may already know all of that I just said, but for anyone else.
That's an interesting one. So let's talk about that for just a second. So if someone has, let's say, a 6 or 7 Beighton score, should they automatically assume they have hypermobile EDS? Is there additional testing needed? And if so, what additional testing would they want to be seeking out?
Yeah, so if somebody has a Beighton score of 6 out of 9, which, probably most people here know, it's the thumb to the forearm, the fifth finger, the elbows, knees, and palms flat on the floor. Those are the 9 points for the Beighton score. So if you have a score of 6 out of 9, that does qualify for generalized joint hypermobility, regardless of your sex or your age. That 6 out of 9 is high enough for any age to qualify as generalized joint hypermobility, which is one of the types of hypermobility. If you have generalized joint hypermobility as compared to one of the other types, you are more likely to have a connective tissue disorder than somebody who has, for example, just localized joint hypermobility. So a person could have hypermobility in just their hips because maybe they have hip dysplasia or something. That's very different. But also there are people that have generalized joint hypermobility for a variety of reasons and don't ever develop problems from it. So I have friends that I've shared this on my podcast. I have friends that are in their 60s and one is even in their 70s, and they're quite hypermobile and they've never had any problems. Of course, if someone's in their 20s or even younger, we can't really say because we don't know what their future is going to look like. But I feel like if someone's in their 60s or 70s and they have no signs of a connective tissue disorder, it's pretty safe to say that they don't have a connective tissue disorder, right? But if someone has generalized joint hypermobility and has some of the other things, maybe they have subluxations, dislocations, widespread pain, maybe they have gastrointestinal symptoms, fatigue, dysautonomia. So they get, maybe they have POTS, they get dizzy when they stand up, orthostatic intolerance, heat and cold intolerance, things like that. Now you're starting to say, okay, this is starting to look like, they might fall into this triad of connective tissue disorder, POTS, and mast cell activation disorders. So that is a very different picture than somebody who does not have those symptoms. So it's always important to think about, what symptoms does the person have and in what systems? Are they in the GI system? Are they in the musculoskeletal system? Because we know that connective tissue is present everywhere in the body, right? So people who have these conditions have symptoms everywhere in the body. So if they go to a regular doctor and they start describing their symptoms, it's so unfortunate, but oftentimes they end up getting labeled as crazy because the doctor's thinking, well, that doesn't make any sense. I never learned about anything in medical school that could explain all of those various different weird symptoms.
Yeah. Plus, as you know, with managed care and everything else these days, the doctor's like, wow, give me one or two. I don't have time for 12.
Correct. Exactly. Yeah. That's exactly what happens.
Okay. Hello, doctors. Is it possible to develop connective tissue issues, developing more symptomatic conditions while and after menopause? I have no idea. So Linda, you're going to take that.
Yeah, definitely. So it's important to remember that connective tissue and the extracellular matrix are, composed of a whole lot of different things besides collagen. I mean, we often think of collagen, but there's a lot of other components in there. And when we hit menopause or as we get older, our estrogen level decreases, and that can greatly impact the quality of our tissues. So it is very possible to get more injuries, have more, problems with your joints and things like that. But that doesn't necessarily mean that the person has a connective tissue disorder. It can be related to decreasing strength of the connective tissue, related to aging. And also, when you have surgeries and things like that, or if you get sick, a lot of people, whether it's COVID or some other infection, that activates the immune system, it activates the mast cells, and the mast cells can release mediators that degrade connective tissue. So it's very, very common for me to hear the story. In fact, you and I have a patient in common who, obviously I'm not going to say their name, but they say I was never hypermobile as a child. And they've had a couple PICL procedures with you actually, and no hypermobility, none. And then had something happen that activated their immune system. And they're like, that's when I started getting hypermobile. My body started falling apart. I started getting all these symptoms. And they have one of the more clear-cut pictures in my mind of how the immune system and the connective tissue, how this interaction occurs and how important it is.
So that's an interesting one. What do we know about that? The concept of immune system, mast cell dysregulation, and connective tissue. Is it that most hypermobile people have mast cell problems, or is it the other way around? Is it mast cell problems cause hypermobility?
So it's probably both. I mean, we don't know for sure, but there's a great paper by one of our colleague, Dr. Larry Afrin, and the title of it is "Some Cases of Hypermobile EDS May Be Rooted in Mast Cell Activation Syndrome." And I believe that is very, very possible, that there are people who have a connective tissue disorder, but it's not a heritable connective tissue disorder. It's one that started with immune system dysfunction. And, we don't yet have really the proper testing to be able to determine, we can determine if someone has mast cell activation syndrome, but we know tryptase, we won't get into that right now, but tryptase is a terrible test. And so it's very, very hard to prove that somebody has mast cell activation syndrome. But I often treat people as if they have mast cell activation. And there fortunately is a diagnostic code for mast cell activation unspecified. And I've really found that since I started treating people's mast cells more and my own mast cells, I've had lifelong allergies, asthma, eczema, migraines, irritable bowel, like the list goes on and on, that nobody ever, connected. And I really find that when you do focus on doing things for the mast cell, that can really help the whole person feel better. And so in some cases, even stabilize their tissues to a certain extent.
Gotcha. Here's another good one. Perineal cysts in the cervical spine, Tarlov cysts. As you know, a lot of hypermobile people show up with these on MRI. Sometimes they're symptomatic, sometimes they're not symptomatic.
Right.
Obviously, you have a direct experience with the Tarlov cyst. So jump into that one. Tell me about all of that and these countless EDS patients that get these MRI reports back. They're like, whoa, what is all of this?
Right. So mine was in my sacrum. And yes, that's the big thing, is determining, is this actually causative or is this, an incidental finding? So for me, what they did was they did a selective nerve root block, and I was being seen at the Mayo Clinic where I trained. I was going back there as a patient in the pain clinic, which I have to say was really rough. That was a pretty low point in my life. I was like, I did not,
because they didn't really get the whole EDS interface, or rough, just a bad time.
Yeah, no, rough because I was able to do so little, and my parents, who are 30 years older than me, are driving me to my appointments because it's like 4 hours from where I live. So my not, maybe she wasn't elderly yet, but older mother is driving me, and I'm laying down in the back seat. So I feel horribly guilty that my mom is trying to navigate, and here I am laying in the back seat. And I never saw myself as somebody who would be a patient in the pain clinic. I just never, I hear this from people all the time, and it's so true. You have to grieve what you've lost, because, most of us don't picture our lives turning out the way we all have loss, right? All throughout our lives, we have loss. But for those of us that have had these kinds of things happen, you need to allow yourself to grieve. And that was something that was really important for me to do. And my doctor that I was seeing there at the Mayo Clinic, pain clinic, finally said, I wonder if that Tarlov cyst is causing the problem. They had done prolotherapy. We kept thinking that it was maybe, because I had severe sciatic type pain going down my left leg. And they kept thinking, they done MRIs and saw some potential injury with the hamstring tendons, and maybe that was it, and maybe some changes in the sciatic nerve. So I was getting all these other procedures. Anyway, finally he said, let's do the selective nerve root block. They did the block, and the pain went away 100%. And I got up off the table, and you have the lidocaine in effect at that time, and I just broke into tears because I had not been out of pain for years. And they said, well, now we want you to do some provocative type things. So I went like running up and down the hall, and it did not hurt. And I was like, this is amazing. Of course, then you get in the car, I'm in the car and I'm laying down, and it starts coming back, and you're like, oh man. But that was very helpful because that was, considered to be very good evidence for the fact that the Tarlov cyst was likely causing my symptoms. So I fortunately had a friend in Dallas, Texas. Kansas City is where he was at the time. Dr. Frank Feigenbaum was my neurosurgeon, and I interviewed him for my podcast. And we talked about, Tarlov cyst and how that's so common with EDS, and how you need to figure out, is it causing the problem or not?
And that's a good one for patients to understand. Just because you see something on your MRI doesn't mean it's causing a problem. And a selective nerve root block, where a doctor goes in and puts the needle in the right spot, paints the area with some contrast to make sure that they know that the numbing medicine is going to go there, and then they chase that with the numbing medicine, can be, a fantastic way to determine if this is really causing your symptoms. And just like Dr. Bluestein said, if they get it right, it's going to be transformative. You will say, wow, that's amazing that pain's not here. Now, if they do it and nothing happens, then we know it's not causing your symptoms.
Yeah, that's a very important, we talked about that a lot in the podcast interview with Dr. Feigenbaum. He does a tremendous number of these surgeries. And there's other surgeons, of course, that do those kind of procedures. But, these are not simple surgeries. So it's the bigger the surgery, the more important it is that you determine that that's the causative factor, right? Because they're riskier surgeries.
Gotcha. So here's a good one for you. Tell me about what you see here. Do you see in your EDS patients some joints worse than others? Obviously, patients have generalized hypermobility, but does it present that way as well?
Yeah, so I have people who hurt everywhere. I mean, I've told this story too about a boy that I saw. He was, I think, 10 or 11 at the time, and he said that he hurt everywhere. And mom asked, everywhere? And he said, well, maybe not my eyelids. And we worked on a variety of different things using that MENSPMS approach. A lot of that education in there is really, really important. And it was education for the parents as well as for the child about pain processing. And, obviously there's a certain amount that you can, that you need to adapt for different ages. Of course, you need to make the education age appropriate, but he really did so much better. And he got to the point where, he didn't need to see me anymore. And I have kept in contact with the mom, and he recently graduated from high school and is just like living like a normal kid. He still has EDS, but he doesn't have that kind of widespread pain that, I often describe it as pain with all capital letters. And that's what it was for me. It was pain, like occupying my brain 24/7. That's all I could talk about. It was just, that's why I say when I was in a really dark place for several years, quite a few years actually. But then once I got a handle on a number of things, I feel like now I have pain with lowercase letters. It's not that things don't hurt, but I can manage the things that I do have much better now. And so some people, it's widespread pain. It's pain everywhere. Other people, it's, left wrist, right elbow, neck, right hip. So it varies a lot depending on the person, but that's really what I try to get at is, how much of this is being caused by, nociceptive type factors? Is it, a tendinopathy or, some kind of injury or, like my intra-articular cyst, what's the biggest causative factor and how much, central sensitization is going on? Is that something that we can address to help the person feel better?
Yeah, and that's a good one to talk about, just the concept of central sensitization and how that's really changed things in the last 10 years or so, understanding that there are people out there that are just generally sensitive to nerve input, and that you've got to sort of cordon those patients off and treat them a little differently. So do you see, Linda, patients who, let's say, have shoulder hypermobility and hips and not generalized? Is that possible within the EDS definition, or is that something else? And really not talking about a normal ligament person who got injured, mm-hmm. but they just have always had hypermobility in those joints.
Mm-hmm, mm-hmm.
Is that possible?
Yeah, no, it's definitely possible. And we know the Beighton score is very limited. I mean, it only assesses a very small number of joints and it's biased towards the upper extremities. So if I was seeing someone in my clinic and they described to me that they were most concerned about hypermobility or instability in their shoulders and hips, I would definitely want to assess other joints and see, what do I think of the other joints that are, maybe they're not having symptoms in them yet, but they still could be hypermobile or unstable, and they're just not symptomatic. Of course, that also depends on their age and what kind of activities they've been doing and things like that. I do want to come back to central sensitization for a minute, just because I do think this is so important. And I love to tell my own story because I feel like it's a hard thing to talk about without people thinking that you're saying that the pain is in their head, right? It's really a very, very difficult topic. For me, I was working as an anesthesiologist, but I had already had my Tarlov cyst surgery, but I still had a lot of pain. So in between cases, if I was on call, I was working in like a lot of smaller hospitals. I'd go and I'd lay down, and I was making it okay, but I was doing locum tenens, and it was tough. It was a little tough, especially if I had to wear lead because I was in a urology room or whatever. But anyway, I watched a lecture by our colleague, Dr. Dan Claw, about central sensitization on YouTube, and the light bulb went off. I was like, oh my gosh. Because for years prior to that, I was aware that in the operating room, I could no longer look like into the incision. The bright lights would immediately trigger a migraine. And if I would be driving in a car and the light would be coming through the trees, like I would have to put my hands up to block that light kind of like going like this through the trees. So I knew that my nervous system was very sensitized, not just to pain, but to other sensory inputs. And so when I learned that there was a word for that, and keep in mind, I was working as an anesthesiologist for over 20 years. So I went through medical school, anesthesia residency, and I still didn't really know what this was. And when I saw this lecture, I was like, oh my gosh, that makes so much sense. So I feel like it's a really important concept for people to grasp. And it doesn't mean that they don't have damage in their bodies, but what it means is that you can have damage in your body, or you can have things that are wrong with your body and not necessarily have pain. So oftentimes I try to work on the mast cell, because the mast cells release mediators that cause and contribute to central sensitization and also cause inflammation. So if we can work on that, it kind of treats the body as a whole. So I feel like that's, rather than playing whack-a-mole, which oftentimes people end up doing. So it's great to have you so close by. We have quite a few patients in common. I probably know more of them than you do, but we have quite a few patients in common, and I love it because what we do is so completely different, and so it's great to have resources like you nearby.
Yeah, and vice versa. One of the things I think we do procedurally is to try to cordon those patients off into what I call the less is more approach. So in those patients procedurally, we try to start with less and then graduate to more. But if there's another way to manage their central sensitization through the immune component without having to throw them on lifelong Lyrica, that's obviously much better way to go.
Yeah.
And this gets right into that one. In MCAS and hEDS, is it purely because of, so this person is talking about the vagus nerve components here to the immune system. And just last week, I think, early last week, Medtronic, or one of the companies, got an approval for a implantable vagus nerve stimulator for RA. So yeah, let's talk a little bit about that whole vagus nerve connection into the immune system and how it maybe is an intersection here in some of the immune problems that hypermobility patients have.
Yeah, I am a huge fan of thinking about the vagus nerve and how can we get into a more parasympathetic mode instead of being in a more sympathetic mode. So for people who are not familiar, the autonomic nervous system controls your blood pressure, your breathing, your pulse, like all the things you don't think about, your ability to control your temperature and things like that. So a lot of people who have symptomatic joint hypermobility or connective tissue disorders have dysfunction in their autonomic nervous system. And usually we're in this like fight, flight, or freeze overdrive kind of state. So if we can activate the vagus nerve, which is the most powerful nerve in the parasympathetic nervous system, which is the rest, digest, and restore nervous system, which can allow us to digest our food and, help with the GI symptoms that a lot of people have, that can be hugely impactful. And, doing something as extreme as a vagus nerve stimulator, is, I'm sure, indicated in some people, but for some people, they can do more simple things like humming and singing and, taking a, cold shower. There's obviously people who do cold plunges and, do contrast type therapy. And, there's a variety of things. There's some devices that you can wear on your wrist. You take a TENS unit. I have this in my Amazon store, and you can take a probe and you can put it on your ear. There's a lot of different ways that you can activate the vagus nerve: meditation, guided imagery. So yeah, I'm a huge fan of that.
And yeah, and so as many of the people watching on the CCI side know, we frequently will do a vagus nerve hydrodissection in some of our patients with autonomic issues as part of that PICL procedure. So that's basically injecting platelet growth factors around the nerve underneath the sternocleidomastoid. So let's see. Here's now, Linda. Do we have you for a couple more minutes? Because I'm trying to get all of the good.
Sure. Yeah. No, I'm good.
The good EDS ones here for you. So basically, this question is: does fitness make a difference in EDS, right? If you're stronger and fitter, are you going to do better than someone who's not? So what are your thoughts there?
Yeah, I mean, having more muscle mass and more muscle tone is hugely beneficial for helping with that joint instability. When I've worked with dancers and other people, if they're, really, really thin and they're not able to eat and they're, in this, kind of state where it's like, I'm really trying to get you to put on some muscle mass to help to support your joints. I worry about that a lot more than I've had a number of dancers come up to me and they talk to me about their hypermobility, but they have more muscle tone and they're able to control their hypermobility better. So yes, fitness makes a huge difference. When I was writing my first paper about pain management in hypermobility, and I came across the word kinesiophobia, which is fear of movement, I was like, oh my gosh, that's what's happened to me. So that's the other thing is, you learn so much by reading all these things. And I was so afraid to move because I would injure myself doing such simple little things. And that happens to so many people with these conditions. And it's totally understandable. And it also happens because if you have something in your body that hurts and you don't know what's going on and you don't really understand how pain processing works, you might think that the best thing to do is to rest and rest and rest and rest. And I had a patient that I saw a number of years ago who was quite young and was doing a dance class where they said at the end of the class, everyone's going to have their splits. So they spent the whole class working on getting their splits. And at the end of that, she had terrible hip pain. And long story short, she was in bed for like a year and a half and had, of course, imaging and stuff like that. And then when I saw her, we went through a lot of different things and I spent a lot of time educating about pain processing and saying, let's start getting you moving, carefully, slowly. You need to start low and go slow. But when I saw her back 30 days or so later, she said, I'm like 90% better. And she had been in bed for like a year and a half. So it's, people can be less active than they want to be for a variety of reasons. It could be because of dysfunction of their autonomic nervous system. So of course that approach would be a little bit different, but generally speaking, yeah, it's not good if we're not physically active. There's a lot of bad things that happen to our bodies when we're not physically active.
And we kind of call that threading the needle, right? You want to do enough so that you can get stronger, but not so much that maybe you piss something off and then you have to go to bed kind of thing. So EDS worsening after a long COVID, any experience there?
Oh yeah, absolutely. I have tons and tons of cases of that where, like we were talking about, I was mentioning that mutual patient earlier. I have lots and lots of people who say, maybe I was a little bit hypermobile, but I was fine until I got COVID. And ever since I had COVID, I have more pain and more problems. And to be honest, I kind of like it when they tell me that story because it gives me something tangible to work with. And that is, again, working on the immune system and working on the mast cell component. When I first started doing this, opened my clinic in 2017, I had my second patient. The mom had come up to me. I was giving a talk at the YMCA and the mom came up to me and she said, this is what's going on with my daughter. She has these non-epileptiform seizure, what did they call it? Psychogenic non-epileptiform seizure disorder and some other things. And she had been diagnosed with EDS. And she said, do you think you can help her? And I said, I don't really know, but I'm willing to try. So I treated her as she was kind of my first like mast cell. Like I thought, okay, this could be a mast cell problem. And she came back and said, I have not had a single episode since I started doing these things. And I was like, wow, that's great. And by the way, of course, I'm sharing all these like great cases. I wish I could say every single one was like that, but unfortunately, that's not the case.
That's called medicine.
It's medicine. Yeah, I know. It's so frustrating. I've helped a lot of people, but there's people that, I haven't been able to get them to a point where I would really like them to be. Unfortunately, these are very, very challenging situations, very challenging. And of course, it's even more challenging if you don't have resources. If you can't afford to buy the supplements that I recommend, if you can't afford to go get the procedures that are recommended, then it's even harder, right? I mean, because we know that people who have these conditions are spending a lot of money out of pocket. But anyway, getting back to the mast cell thing super quick. So I was giving a talk at a mast cell conference. And in the process of that was, of course, doing this literature review. And I realized, oh my gosh, probably more of my patients have mast cell problems than I realized. And maybe working on the mast cell component will help their pain more than I thought. So that's really when I made the shift. And that was a few years ago. And that's when I think my outcomes started to get better.
That's interesting. Yeah, and just so that you know, Linda, we just started a program. Hopefully I'll be getting the names here pretty soon, but we opened up 15 slots a year for PICL pro bono.
Oh, wow.
So basically they have to be at a certain income level.
Right.
And then what we'll do is we'll take abstracted impact statements. And if we have more than one applicant for a slot, then we'll put it onto the 2 online groups we have and just have people randomly vote, just sort of a random selection. But there are 15 slots a year now that it'll be no cost to the patient.
That's amazing. I obviously, that's fantastic to learn about. And I definitely will help spread the word about that, because I think that's incredible.
Yeah, it should help. Now, this is a super interesting one. Hormone replacement therapy, is it different for EDS, connective tissue disorder people, or is it just the same as standard HRT once you get into that perimenopausal, postmenopausal period?
Right. And I get asked questions about this all the time. And I have talked about this on my podcast, although I definitely plan to do it more. In fact, I have an interview scheduled with Dr. Rachel Rubin in the fall, or I'm not sure, maybe it's not even actually on the books yet, but anyway, she said yes. So if people have more questions about this, I have more of the connective tissue expertise. She's a urologist, but she has incredible expertise on menopause, and recently was one of the people to talk to the FDA about the rules surrounding testosterone and things like that. So I would say that it's different in the fact that people with connective tissue disorders may need even more support than, connective tissue typical type people. So I think that, we still need to consider all the factors of, your cancer risk and, potential contraindications to hormone replacement therapy. But I think that people with connective tissue disorders may benefit even more from having hormone replacement therapy, which may or may not include testosterone. I do prescribe testosterone for some of my patients, and oftentimes they do find it beneficial. Of course, that helps build muscle mass and can have some anti-inflammatory effects, can be beneficial for mood and some things like that. Now, of course, you have to be very careful with dosing and that kind of thing. But hormones are very impactful. One of the people that I interviewed, Dr. Kelly Casperson, she says, we call them, oftentimes they call them like sex hormones, but they're brain hormones. They have effects in the brain. So, yeah.
Let's see here. Slipping ribs and EDS. Do you, I don't think it's necessarily directly related to CCI, but certainly a lot of hypermobile people have rib issues. How much do you see in your patient population? How many of them have rib issues? Is this a particularly disabling thing for hypermobile patients?
Yeah, I see this a lot. And I think that, like most things, that there is a spectrum. So some people have more mild symptoms. And then I have had some patients that have horrible, horrible ribs. I'm thinking of one person in particular that I have that, it is really, really interesting that the spectrum, because, I have the same diagnosis as this patient of mine, but I can tell you my body is definitely built way better than hers. Everything in her just falls apart. And she has terrible mast cell activation syndrome. And we've tried working on that. But anyway, she's had multiple rib surgeries. And this is a very difficult problem if you're on the more extreme end. I feel confident that I have subluxed ribs on a few occasions, and oh my gosh, is that painful? And fortunately for me, though, it resolved itself. And there's some things that I'm able to do with foam rollers and exercise and things like that I generally am able to keep that kind of a problem, very well at bay. But for people who really have that as a significant problem, I would definitely suggest that they check out the interview that I did with Dr. Adam Hansen on my podcast. I don't remember the number offhand, but he has trained many, many surgeons. He has a huge base of patients that he's operated on. He's a thoracic surgeon.
Gotcha. Okay, so I think we're starting. Okay, so I think we're now getting more into CCI questions. Well, Linda, I want to thank you so much for spending time with us today and answering all these great questions about hypermobility. And please check out Linda's podcast, Bendy Bodies. it's on, I think it's on all the podcasting.
Yeah, it's everywhere. BendyBodiesPodcast.com is the website. And can I quickly address, somebody submitted a few questions when I shared your post.
Oh, yeah.
And okay, if I can quickly address those. So I'm going to go in reverse order because I want your opinion on one of them. I want to hear how you answer that one. Yes. So the first one that they asked is, the middle one, are cervical collars bad to use? So of course we know that there's soft collars and there's rigid collars, right? I'm going to address this as a more general thing. And then I would love for you to throw in your, opinion about this more specifically to CCI. But, I think it's so important for us to distinguish between a soft brace where the joint can still move and a rigid brace. If you use a rigid brace too much, yes, the muscles will weaken. But sometimes you need that for support and for stability. If you're using a soft brace, then maybe that's going to help you with joint alignment. And if it's, a soft collar, which, I don't know how much a soft collar actually does, but for some people, I think they do feel like it is somewhat supportive. Then you're still using muscles. And so I think it's very important to make the distinction between the two. If I have a patient who I'm recommending a cervical collar to, depending on their circumstances, I will often say, use it for 15 minutes when you feel like you really, really need a break, but try not to get dependent on it all the time. Now, there are times where I've seen some of the neurosurgeons say, use it 24/7 for, like a week or something to see how many of your symptoms that improves. And that may give you an idea of how much is related to your CCI. But what's your opinion about cervical collars?
Yeah, I kind of agree with everything you said. At the end of the day, a collar test can be an important piece of information. Soft collar is probably better than a hard collar. Having said that, you got to thread that needle between getting some relief from the collar when you really need it versus making those muscles weaker, because half of stability is muscles, half of stability is ligaments. So you need both. So I always tell patients, listen, if you've got to use one, I understand, but realize that the more you use one, that functional hole gets dug deeper and deeper and deeper and deeper. And the deeper that functional hole is, the harder it is to climb out at the end of the day. So yeah, pretty much agree with everything you said, and just thread the needle between using it, but not using it so much that you're getting substantially weaker.
Yeah, excellent. Okay, then the next question was, should chiropractics be avoided with EDS, specifically with CCI? I did a podcast interview with a chiropractor, and I definitely recommend that people be very cautious and choose a chiropractor very carefully, especially when it comes to the cervical spine. But there are chiropractors who have a lot of expertise in this area and can be helpful. So I think it's all in who the chiropractor is, what kind of techniques they're using, and are they working as part of a team, or are they, kind of out there doing more aggressive kind of things. So, but I would love to hear your thoughts on that.
Yeah. So for us, we really try to focus on upper cervical specific chiropractic, low force, low amplitude techniques. So that's going to be NUCA, AO, orthospinology, Blair, those sorts of upper cervical chiropractic techniques. CCI patients in general do well with, because they're very focused on using vector adjustments to try to get the C1, C2 area better aligned. And for some of our patients, they just do well, and then we don't see them again. And for most of our CCI patients, they will do well for a time period, and then things will come back out. What I tell them to stay away from is obviously the classic take the head, turn it kind of chiropractic adjustment, because that's probably not going to fit well with CCI. It's probably not going to fit well with EDS either.
Mm-hmm. Yeah. And I had that done to me in my lower back, and oh my God. And I have osteoporosis. I thought that I had something fractured. I was in so much pain that night.
They call that the $1 million roll.
Yeah. Yeah. And it was a DO that actually did it. But then when I went back to him, because I wanted him to know what happened, And I went back to him and I said that was too aggressive. He was very young, I think probably relatively new out of school. And so we had quite the conversation. And he said, well, I trained when I learned my osteopathic manual techniques, I was trained really very much like a chiropractor. And I was like, okay, I didn't know that when you proposed doing, an adjustment on me, because I had only previously had, like, physical therapists sometimes will do, gentle adjustments. So I'd never
like
had
muscle energy technique, which is very, very gentle.
Right. Yeah, exactly. Okay. Great. So then the last question, and I want to preface this by saying that I first became interested in coming out to your clinic when we had a mutual patient, and she had shared with me the instructions that your clinic gave, and she wanted to know exactly which supplements or whatever to avoid. And I was reading through this and I was like, wow, this is very detailed, and so much thought had gone into those instructions and the preparation. And I thought, okay, now I'm starting to get more patients. I've only been in this area for 3 years, but I was starting to get more patients that were, coming out to your clinic, or they had already been there and coming to me for pain management for other things. Anyway, so I said, I want to come out there and take a tour and kind of see what you guys are doing. And so that's how, like, that's why I first wanted to come and observe your practice. And I appreciate you letting me do that, because I learned a lot from doing those kind of things. I've gone and shadowed a few people just so I can kind of get a better sense of what things my patients may or may not need and be doing. So thank you for that.
Yeah. And realize that when I started in this world 20 years ago, regenerative medicine, 2005, we started culture expanding adult bone marrow mesenchymal stem cells. We had to have lab facilities to do that. And there was no textbook. There was no one else on earth using that in humans at the time. But one of the things that we started to find out was what worked and what didn't work. So even in culture expansion, for instance, ACE inhibitors would cause culture expansion failures, or a patient on a corticosteroid would be another culture expansion failure. So we started to see in vitro what was causing some of the issues in the ability to grow these cells. And so that's kind of where some of those things came from. And then there's that whole concept of we need a little inflammation to do what it is we're trying to do on the acute side. And so, some of these patients have to come off those anti-inflammatories. And as you know, with the advent of biologics now being expanded into everything from migraine, headache care, from its origin in rheumatology, you get so many things right now that have very powerful anti-inflammatory actions.
Mm-hmm. Yeah, absolutely. So you're saying that you discovered that patients who were taking certain oral medications before they would have these procedures would have
we couldn't grow their cells. And then we would take them off the med and we'd say, let's try again, and their cells would grow fine.
Mm-hmm. Yeah, interesting. That's very interesting.
Which is super concerning, right? Because we don't test our meds that way.
Mm-hmm.
But if someone can't grow your stem cells in culture, if you're taking a certain meds, it's probably not a good thing.
Mm-hmm. Yeah. And so the devil's in the details, right? I mean, that just points to how incredibly important it is to be really paying attention to all of those things. And so that's really helpful. And then the last question that I have for you is, if someone has a diagnosis of CCI and they're on the more extreme end, so they're having some, they're having not just pain in their neck, but they're having neurologic symptoms of whatever sort, and they're contemplating surgery. They're at that point. They've done, for example, maybe NUCA. They've done a variety of things, medication-wise, whatever. Do you have thoughts as to how they would best determine if going the route of a PICL might be helpful, or, gosh, I think it's to the point where, no, I need neurosurgery and a PICL probably is not going to help me. Is there any way for a person to know that?
Yeah. So we automatically don't allow certain patients to go forward. So some of the examples there would be if there's very clear brainstem compression on their imaging that's very clearly structural. Or, for example, a low claviaxial angle patient that's in the 120 to 125 range, we will probably simultaneously have them see a surgeon who does CCI. At the same time, we say, well, we're going to try this, but we want you to have that consult. Or some of the larger EDI patients at lenodental interval inflection, if that's in the 6-7 range, then we will again have them see a surgeon, get a surgical opinion at the same time that we're seeing them. And then based on how much that's moving, how functional or non-functional they are, we'll give them the option of either doing what we're doing or saying, no, you have to go to get that surgically repaired. So there's a list of things like that. And then on the other end, we type all of these CCIs. So there's a typing system I developed that focuses on which ligament is problematic. So 1A, 1C, 2A, 2B, 3A, 3B. So, we can say, for instance, that the 3A patients can just do posterior injections. They don't need a PICL. That's just forward translation at 2-3. And they can even just do posterior simple prolo where they are, because that responds well. But if it's a 2B, they're going sideways at C1, C2, then they're going to need those internal ligaments treated. So on the other end of this spectrum, some logic there as well.
And I take it that some unfortunate people are going to have, they're going to have 1A, 1B, 2, they're going to have multiples.
Yeah. And so then it's a little harder to figure out. And sometimes I'll tell them, well, if you have a 3A, that could be driving many of your symptoms, give it a shot locally and see what happens. And then if that doesn't work, we can always see you.
Okay. And I apologize because I said that was my last question for you, but can I ask you another question?
Sure. Go.
Yeah. Hopefully people will find it interesting, because this is something else that people with EDS deal with quite a bit. And I had a patient, another mutual patient, I don't think of yours, but in your clinic, who had symptoms very consistent with a CSF leak. And they had a targeted cervical epidural blood patch, and it completely resolved their symptoms. That was a fantastic outcome. It was probably one of the best, that I have seen. Because I've treated a lot of people that have had blood patches, and some of them have had lots and lots of blood patches, and they, are still not doing well. Of course, I see a biased population, because if I see people who aren't doing well, like they're not going to, of course you do too, but not doing well in different ways. Right. In any event. So, can you tell me, because I would like to know for my own practice, but also I would imagine other people are interested, when it comes to CSF leaks, because we know that's something that commonly happens when you have weak connective tissue. What is the process at your facility? Is this something that you guys like to treat there, or what are your thoughts about that?
Yeah, we can always treat CSF leaks, and this is a common decision matrix problem. They've got CCI. They also have some components that look like a CSF leak. Many times they're in the CSF leak pipeline.
Right.
So for example, I just had a guy come out from the UK. He's got a bunch of other issues going on top of the CCI. Someone tried to put in 2 IJV stents, one on top of the other, which clotted. But his UK physician was convinced he had a lumbosacral CSF leak. I wasn't so convinced, but I said, listen, you're here. Let's go ahead. We'll do your PICL. I'll do a lumbosacral blood patch at the same time. We're not going to get a great amount of diagnostic information out of that, because we're doing 2 things at once. But at the same time, you should be able to get out of the bed here within an hour or so of recovery and feel great if you have a lumbosacral CSF leak. So yeah, we work those up. Realize the biggest failure, I think, for CSF leak blood patches is that they are hard to do to get extensive coverage. So more commonly in our insurance-based system, what happens is someone sticks a single needle in, usually IL epidural, and they put a lot of volume in and kind of hope for the best. You really track where that stuff goes under serum fluoroscopy. you'll often find, well, even though I put a lot of volume in, it went 2 levels and then the rest of it went out the nerve roots. So I've got to go above that, do another one. And that only went this far, so I got to go above that and do another one. So I think the biggest reason for failure of those is just that in our insurance system, everyone wants a single shot, one and done on the doctor side. And they rarely get a look at how much coverage they got when they're getting those blood patches. So yeah, we can certainly do them, but it just takes time. So for instance, covering the entire lumbosacral spine, if you do it right, is probably a minimum of 3 up to 6 or 7 injections from L1 to the sacrum, including a caudal to backstop it. But yeah, we're happy to do it, but we frequently see people in that. Now they're in their own little pipeline. So many times I'm just saying, hey, finish that pipeline out before you come over, because if you've got a CSF leak, then obviously get that treated.
Yeah. And like you said, it definitely can complicate the picture. And sometimes it's hard to figure out what is the biggest thing that's driving the person's symptoms and where can we have the biggest impact. So, well, thank you. I thought, well, I'll pick your brain a little bit on that. So thanks.
Yeah. Well, that sounds great. So Linda, thank you so much. You spent an hour with us. Thank you for that time and answering all these great questions. Guys, I'll stay on and try to get to some of the CCI ones, but thank you for spending a Sunday morning with us.
Yeah, absolutely. Thank you so much for having me. It was great to see you again.
Great to see you. Bye-bye.
Okay, bye.
Okay, guys, so let's get to some of the questions I didn't get to. Super interesting from Dr. Bluestein. Dr. Bluestein's podcast is Bendy Bodies. So I really invite you to check out Bendy Bodies here. Let's see here, trying to get to the CCI ones here. Okay. Raj, hi, doctor. I hope you're well. I remember you saying that if a patient gets fusion on C1, C2, sometimes their symptoms don't go away. Why is this, as the segment will not move anymore? Yeah, I don't remember saying that in particular, but certainly any fusion is only going to reduce symptoms if it's getting rid of the things that are causing symptoms. So for example, if you had a 1-2 fusion, you could certainly, you're going to then overload 0-1 and you're going to overload below that at 2-3. So if you had symptoms above or below, it's actually going to make those symptoms worse. And if you didn't have symptoms there, you can develop symptoms due to that adjacent segment disease. So maybe that's what I was talking about there. Lisa, why does CSC not add into the problem list hEDS is suspected? We usually do. So let me know if for some reason that didn't get added. But yeah, we usually do if it's something that we are working through. Let's see here. Trying to get to the CCI ones here. John Gardner, hey, just curious, what's the most stem cells you've ever seen extracted at one time? Yeah, John, the TNCC counts that you get, realize, are not stem cell counts. They are total nucleated cell counts. So it's the total number of cells, of which a fraction of that is stem cells. As far as the biggest TNCC number we've ever seen, usually it tops out at around 3 or 4 billion, somewhere in there. And frankly, if it gets too much higher than that, we can be concerned about those numbers. So we've certainly seen that before. But realize that those are total cell counts. John Gardner, after my PICL number 1, my chest rib chondrochondritis went away. How can that happen if you didn't inject my ribs? Amazing. Yeah, John. So, realize that the upper cervical spine is a big control center for postural alignment. And if you have bad information coming from the upper cervical spine, that can change your overall posture, right? And it's called the righting reflex. So if I believe that this is straight up and down because there's bad information coming in from my neck, I have to right my visual field. And I'm going to right my visual field by doing this, meaning I'm going to make my visual field perpendicular. that's obviously putting all sorts of pressure on my ribs and everything else. So if we normalize the upper cervical position sense, frequently we can see downstream things in the ribs, thoracic spine, and lumbar spine go away, because now the person can determine what is straight up and down. Molly, is it normal to have muscle spasms right after a PRP of the cervical spine? Can I take a muscle relaxant? Does that? So you can usually take a muscle relaxant. And Molly, I'd need to know so much more about who did the injection, specifically what was being injected. You know, there's 20 different kinds of cervical spine injections, so hard one to answer. Let's see. Got to that one. Got to that one. Molly, does scoliosis need to be treated differently if one has hypermobility? No, I mean, from our perspective, Molly, we would treat it the same. Is Botox to suboccipitals and more structure safe for those with hypermobility? You know, Molly, I would say generally not. The biggest problem with Botox in hypermobile patients or unstable patients is that they need muscle mass and tightness in order to provide stability. So Botox ratchets that down and it decreases the strength of the muscle. So if we decrease the strength of the muscle in somebody who needs that muscular tone to provide stability, then all heck could break loose. And that's kind of what we generally see in many unstable patients who are given Botox. And every once in a while it works because we get it dialed down just the right amount, but oftentimes it makes it too weak, and then the patient gets more unstable at that spot. Let's see here. Is there a level of inflammation that's a contraindication to ligament injections? Not really, but I think, again, as Dr. Bluestein talked about before, if the patient is essentially sensitized, then we will go ahead and take a less is more approach, because that's going to cause too much additional flare-up in that particular patient. Let's see. Brittany, can you speak to Prolo versus PRP for tightening loose ligaments? Yeah, so I often say that you can put the three technologies that are most commonly used in order here, right? You start out with prolotherapy. Prolotherapy is the least powerful. So let's say we use an SI joint hypermobility situation. A patient with SI joint hypermobility who has normal ligaments, female usually, would take somewhere between 6 and 8 prolotherapy injections to get better. And then you can half that if you upgrade to PRP, 3 to 4 PRP injections to get better. And then you can half that again if you are going to do bone marrow concentrate. Now, generally about 1 or 2, maybe more, but you can see the power of those being quite different for tightening ligaments. Can connective tissue disorder present in the TMJ? It certainly can. Brittany, occult tethered cord in CCI. Yeah, I think I've talked about this one quite a bit, Brittany. Occult tethered cord can be kind of interface with CCI. I think the biggest problem is we don't really have great occult tethered cord diagnostic guidelines right now. We know what a tethered cord is because we can see that on MRI, but what we don't have is occult tethered cord diagnostic guidelines that allow us to take 100 people off the street, for example, do a prone MRI and see how many of those patients who are totally normal have an abnormal prone MRI. And until we get that, it's going to be very difficult to make that diagnosis other than just clinically. the most common issue that we see in our patients who have been diagnosed with occult tethered cord is that they've got an independent low back problem that was never diagnosed that's causing, for instance, some of their urinary symptoms or some of their back pain symptoms. And then that went right over the head of the neurosurgeon they saw. They have things on their MRI that are clearly showing problems. Their exam shows that they have a separate low back problem that may be linked to the upper neck, but is distinct. And when we treat that low back problem, those issues go away. So it's not an occult tethered cord. So that's the most common thing that we see. Let's see. Is relief of CCI symptoms from taking Benadryl, sign of MCAS, playing a big role? Yeah, that's a good question. If you have relief of CCI symptoms from taking Benadryl, I would wonder whether or not you have CCI or something else causing those symptoms, maybe more related to MCAS. So that might be a good reason. Definitely check out what Dr. Bluestein does here in Colorado as well, because that's a really good one for her, because I know they're treating a lot of MCAS there, and through treating MCAS, they're getting rid of some of the symptoms associated with a large spectrum of things. Hi, does each doctor at Centeno-Schultz have extensive experience doing EPICL in patients with central sensitivity? Is that something you would specialize more than others, perhaps? Yeah, each doctor at CSC that's authorized right now to do the EPICL, and those are doctors that have trained specifically with me on EPICL, is able to diagnose central sensitivity. Now, having said that, each doctor is different, right? We all have our areas where we focus more, our areas where we focus less. Just based on personal experience, I am probably maybe a little bit more sensitive to central sensitization, pardon the pun there, simply because I've seen a good number of patients flare up if you do too much in those patients. So if you see another doctor, Centeno-Schultz, and you think you might have central sensitization, and what does that look like? That looks like you can't tolerate procedures, you blow up from procedures, even a vigorous massage will flare you up for weeks, that kind of thing. You can't tolerate touch in certain areas, then certainly let me know, because I'm always happy to re-powwow with the doctors on that less is more approach. Let's see here. As my neck gets realigned with Blair Chiropractic, my low back spasms constantly. It's been this way since my whiplash in 2016 and another in 2020. Any comment appreciated? Yeah, Mark, so the question would be, is there a separate low back issue that needs to be looked at? So that would be working with the doctor you're seeing at Centeno-Schultz to delve into that back issue, and realize that many, many times on low back MRIs, we see things that aren't read out by the reading radiologist, but that we know are related to chronic back issues. Things like, for example, atrophy of the lumbar multifidus, which we know can lead to instability and back and leg symptoms, but the reading radiologists aren't actually paying attention to. Julie, do you have a recommendation for a particular vagus nerve stimulator? Truvega is the one that I've seen out there. We tried it on just a few patients, so I can't say I've seen it enough to know is one better than the other, but that's the one we've used. Let's see here. Kate, PICL scholarship, amazing. Thank you. We do have that program, Kate. I'm hoping to get the first list of names that our call center has been working on here within the next week. I know I've sent an email just while I was in Vegas at lecturing at a medical conference to my staff to try to get those to me. Let's see. Stacy, you said to thread the needle regarding pain and exercise for PT, but what about PT for CCI causing severe dizziness, vertigo, and imbalance that persists for 48 hours or more? So I think what you're saying here, Stacy, is if you have pain, imbalance, vertigo every time you go to physical therapy, then you're not in the right kind of physical therapy program, right? If you've got craniocervical instability causing that, then you may need to get the craniocervical instability component treated first before you can tolerate that. So threading the needle only works if you can do some activity and it doesn't really flare you up, but you have a line there where you know if you cross, then it'll cause a flare-up. But if that particular activity, like physical therapy, always flares you up, then it's not really threading the needle. It's something needs to get fixed. Dr. Bluestein is amazing. I agree. General question for Dr. Centeno. I'm scheduling an initial appointment with you, but wondering if you recommend getting DMX for a virtual appointment. How long is that DMX good for before you want to redo for a PICL? Yeah, I definitely would recommend getting a DMX, Claire. We pre-screen all of those. So if you don't have any movement-based imaging, it's unlikely that we're going to grant a telemedicine visit. So, but if you do have something like an upright MRI, then we usually do. So regardless, it's probably always a good idea to get a DMX because that's going to show different kinds of instability than, for example, an upright MRI. Christy, AO Chiropractic, the best. I agree. There's some really good ones. We've had patients have amazing responses as well. Can't function without my chiropractor. Stacy, I'm referring to light touch on the neck. The PT calls it muscle energy technique. I'm 6 months post PICL and have hypermobility, and my PT is an EDS specialist. Yeah, Stacy. So if muscle energy is flaring you up, then definitely time to back off from the muscle energy technique. So I would reach out to your doctor at the clinic, at CSC, and obviously feed that through his loop there, because that's going to be critically important to understand in the context of your health history. Let's see, what else do we have here? Christy, I was on a Jovi for both PICL procedures and had no problem with the healing process. That is good to know for sure. Having said that, that's one of our restricted meds because it'll block inflammation, and we don't really have any data on how it affects regenerative medicine procedures. It's certainly possible that in most patients it won't make a difference. Mechanistically, it's more likely than not to be a problem. Matt, great live. Thank you. Thanks, Matt. Let's see here. During a hands-on exam, how do you determine if a neck muscle isn't receiving proper nerve signal? What's the test? Well, if a neck muscle isn't receiving any nerve signal, then it's going to atrophy. So we're going to see that atrophy. If it's not firing correctly, that can also be determined. So for example, we'll see muscles overfire or underfire and be inhibited. And that's fairly easy to see with movement, for example, on a hands-on exam. Amity rehab. Is dextrose prolotherapy safe in upper neck for ligament instability? Can also be injected in the VDL, monitor a bridge, and RCPM. Is it safe to inject in the facet joint itself? There's no problem with injecting dextrose. It's just the doctors offering dextrose prolotherapy generally don't have the experience to inject it in the upper cervical spine. So that's when it gets dangerous. So for example, if you were by accident to inject dextrose prolotherapy into the vertebral nerve, into the vertebral artery, that's a really bad day for everyone. It will kill the artery, cause it to go into spasm, and then that patient will get a stroke. Now, if you were injecting PRP into that same vertebral artery by mistake because you didn't really know what you were doing up here, then that's less of an issue, but it could cause a clot and cause a stroke. Same thing with bone marrow concentrate. But of those three things, dextrose prolotherapy would probably be the highest risk. So we're injecting the highest risk thing, generally in providers who aren't trained at all how to inject the upper cervical spine safely. So I would say that those two things usually aren't compatible. Someone who's doing dextrose prolotherapy and someone who knows how to inject the upper cervical spine. Brittany, upper cervical symptoms include headaches, balance issues, dizziness, and upper neck pain primarily, and DMX will show most types of CCI, not all types of CCI. Okay, guys, your new app is great. Thank you. Okay, I think that's it. We're in at about an hour and 21 minutes here. It was great to have Dr. Bluestein on. I'm going to try to do that a bit more here and there, bring on some interesting people who kind of interface with the CCI world. And we usually get some great things. That was a great one with Dr. Bluestein. I will be here next week. And then I think the week after that, I'm going to be on fall sabbatical. So I think we've got one more here. And then I'll be on fall sabbatical for a while, but I will have content that continues to go out while I'm on sabbatical. So thank you so much for spending a Sunday morning, early afternoon, depending on where you are, could be the evening where you are, with us. And I really appreciate you taking the time, and I appreciate all the great questions. And I will be back next week with something else. Thanks so much for watching. Have a great day.